This is the 7th Walter Whitehouse lecture, and the first one given since his death last October 9th. We have with us some guests: his wife Rebecca, his sister Elizabeth, his son Mac, and his brother Frank. May I ask you to stand so that you could be recognized? It is now my pleasure to introduce our Whitehouse lecturer this year, John Kirkpatrick, Jr. John was born in Waynesboro, Pennsylvania, took his undergraduate training at Franklin and Marshall College and his MD training at Temple, and then spent a year at Harvard. He went through his radiology training at Temple too, and then spent a year at the Children's Hospital in Boston. He joined the faculty of radiology at Temple in 1956, rose through the academic ranks to the rank of professor in 1965, and then came to Harvard as professor of radiology in 1974 and the radiology chief at the Children's Hospital. He now holds the position as the chairman of the Department of Radiology at the Harvard Hospitals. He's had numerous academic honors and awards, and it would be difficult to detail them all for you now. So numerous are they, but distinguished nevertheless. Many honorary lectures has he given, and he served on the editorial boards of many societies and journals. He has been an officer of a number of prestigious professional societies, including the New England Röntgen Society, the International Skeletal Society, and the Society for Pediatric Radiology. We regard him as the Dean of Pediatric Radiology. I don't know whether anyone has coined that phrase for him before, but I'm coining it now. He is the author and the co-author of over 100 scientific papers and numerous book chapters, and he is best known for being the co-author of a very successful textbook on orthopedic radiology, which he co-authored with Dr. Eggeter, a pathologist, and a book which is now in its 4th edition. The title of his lecture is Pediatric Pulmonary Disease as Encountered in Adolescents and Young Adults. John Kirkpatrick.
Thank you, Bill. Debbie, you're right. She said when he puts this around your neck, he pulls it very tight for a while and it's hard to breathe, but it's okay now. Now I'd like to thank you, Bill, Rhoda, and Mrs. Whitehouse, and I can remember everything. Brother Frank and Sister Elizabeth and Mac, and you're a surgeon, I understand. And all of you who have come today, I suspect not so much as to hear me, but to honor Walter Whitehouse. I didn't train here, but I have fond memories of Walter, and I guess the best is, as a young radiologist, Jane and I were in Acapulco one time, feeling a little bit lost, but a couple of days on the sand with Walter, and we felt part of the group without any problem. And I think, as I've read his work, and as I've heard of him, and as I've seen what he did with the yearbook, there's no question that he's someone who could be and was and is still considered to be a friend to an awful lot of people. So I consider it a very special privilege to have been asked to participate in this lectureship, which seems to me to be entirely fit and proper, a lectureship in his honor. I picked this topic for 2 reasons. Number one, because I've been interested in the chest a bit, and 2, because I also was aware that this was one of his interests. Could I have the lights and the first slides, please? Now, as we think a bit about pediatric pulmonary disease as one encounters it in the adolescent and the young adult, It seems to me that one can categorize these abnormalities in one of a couple of areas. One of them obviously has to do with congenital anomalies. And there's no question that we see bronchogenic cysts in babies, we see them in children and in adults as well. And sometimes they're found serendipitously, and sometimes they're found because they cause symptoms. Well, I didn't bring a bronchogenic cyst, but I brought the films on this 24-year-old man who obviously has an abnormality of his sternum. And maybe the lights could be down just a little bit if we could, please. This young man had been operated upon at the age of 10 years by one of the surgeons at the Children's Hospital for pectus excavatum deformity. And he did very well post-operatively, and one can see that the heart's forward and the sternum is in pretty good shape. But at 24 years of age, he felt it necessary to come back to see that surgeon because he was playing hockey and he got short of breath. And as you look at the films, it's apparent that the heart is shifted to the left, and there's no reason for it to be so because the pectus has been corrected. But as you look at it a little more closely, it's apparent that this side of the thorax is more opaque, or more lucent than it should be. And when an expiratory film is obtained, it's apparent that it's most likely the right middle lobe that is abnormal. As we looked at it a little closer, it became apparent that there was a funny little blob right there, and fluoroscopically that did not pulsate. So the possibility arose that this represented congenital bronchial atresia, and that this was mucus on the distal side of the atretic segment. Now, this anomaly is most commonly encountered in a child, but this is a man, 24 years of age. And when the bronchogram was performed, we see the lower lobe compressed, the upper lobe compressed, this large lucent area, and a vague area of density there. And when the middle lobe was resected, this is the mucus plug on the distal side of the atresia. So this anomaly, which is most frequently associated with the newborn, the infant, or the child, may in fact be present without overt signs and symptoms for a number of years. And there have been reports of adults hospitalized with the suspicion of tuberculosis because the area of obstruction became emphysematous, the alveolar walls broke down, and the appearance was that of cystic disease. Now, this is a 9-month-old child who had a routine examination. Actually, there was a question of this family having been overseas for a number of years, and so this was part of a, quote, complete physical examination. And in this decubitus study, one can see that a portion of the upper lobe is showing evidence of volume loss. The minor fissure is here, and this is the posterior segment of the upper lobe, overdistended, and here one sees adjacent to the hilum the round ball of mucus on the distal side of the atretic bronchus to the posterior segment of the upper lobe. This little marker may be large in some instances, it may be small, as on the expiratory film of this 7-year-old child. And in this instance, it was the apical posterior segment of the upper lobe that was obstructed. And I shouldn't leave this without suggesting that this can be seen in the immediate newborn period, a baby with a very curious density, examined in the first day of life because of rapid respirations. And there was a lot of discussion as to what this might have been. And it was interesting that when a bronchogram was performed, the bronchi to the apical posterior and anterior segments did not fill. But when a pulmonary arteriogram was performed, there was vasculature to that area. And when the chest was opened, this was a very large area of lung, looked normal but was big and firm, and when this was further dissected, there was bronchial atresia, and what we're seeing is fetal lung liquid that has remained in the lung because the normal egress for it was interrupted. You know, the fluid is formed in the lung. It's very important. It contributes to amniotic fluid. It keeps the lung in a certain stage of almost inspiration, and that allows for normal formation of the thorax. That liquid also contains surfactant. If it can't drain through the bronchi at the time of birth, at birth one will see it looking opaque as it's retained. Over time it is absorbed, and then one will see that air has gotten into this area via collateral channels, and within a few weeks one may see a plug of mucus in the bronchus on the distal side of the atresia. So this is a congenital anomaly that we all usually associate with those who are early in life, but which can be seen, as I've demonstrated, in the adult. Now sometimes congenital anomalies are repaired and one is faced with residual abnormality. And I wonder what most of us would say if we got this film. This is an 18-year-old young woman. If we got this film in a pile that said, "Rule out pneumonia." As you look at the chest, the lungs are equal in volume, the heart is normal in size. But what is apparent is that the vasculature to the right lung appears normal, but the vasculature to the left lung is abnormal, particularly in the lower half. Notice that the vessels do not branch and taper. They're smaller. There are fewer of them than is expected. And in this blow-up of the bases, one can very readily appreciate the difference in the vasculature to the two sides. Now, I think that this raises a question as to what this might be. But in fact, it's very simple, because this child at birth had a congenital diaphragmatic hernia on the left side, and one sees that the heart is displaced to the opposite side. The gut was relatively airless or the abdomen, because most of the gut was in the chest. The patient was operated upon, and at 7 days, one sees that the heart now is to the left because of the very small size of the left lung, the hypoplastic lung. At 5 months, the lung is becoming of normal volume on the ipsilateral side, but already one is beginning to appreciate the fact that the vasculature is abnormal. At 5 years, it's apparent that the vessels are abnormal, and at 18 years, one again sees these abnormal vessels. And when studies utilizing radionuclides were done, it was apparent that the left lung had somewhat less ventilation than did the right. It was equal in volume, but perfusion was considerably diminished on that side. And I think it's interesting to go back and figure out why those vessels are abnormal and why the lung should look as it does in patients who survive, or many patients who survive, diaphragmatic hernia. I think that pulmonary hypoplasia in association with congenital diaphragmatic hernia has been appreciated for a long time. And in 1968, Dr. Burden and his associates noted that one might stage the pulmonary hypoplasia as being insignificant, severe and bilateral and often lethal, or unilateral, and these were marked by survival in most instances. But later, there appeared to be emphysema of the ipsilateral lung. It also was and is appreciated that pulmonary hypoplasia may be associated or cause increased pulmonary vascular resistance, which results in decreased pulmonary blood flow, increased right to left shunting, then alterations in the oxygen, CO2, diminished, increased, the pH goes down, and there is death, or there is a vicious circle that is set up. Well, to look at this a little closer, Dr. Lynn Reed and her associates, in looking at the lung, taught us that the bronchial tree is developed by the 16th week of intrauterine life. Now, after 16 weeks, you may get a few very peripheral generations of airways, but for the most part, that which we have as adults, we had at the end of 16 weeks of intrauterine life. The alveoli, however, develop after birth as well as in utero. And it's been said that there are 24 million terminal air spaces at birth, and these increase to 250 to 300 million, depending upon the size of the individual, by 8 to 10 years. And after that, they get bigger, but they do not become more numerous. Of very much significance as one thinks about diaphragmatic hernia, the pre-acinar vessels, the pulmonary arteries and veins, follow in their development the development of the airways. And the intra-acinar vessels follow the development of the alveoli. Now it becomes apparent then that this developing airway, at 3 weeks, it's a bud from the sort of common foregut, and then by 4 weeks it's starting to branch. By 6 weeks it's looking sort of like a tracheobronchial tree, and again by 16 weeks it's complete. And one can look and see that as it's developing at the 8th week or so, as depicted here, the pulmonary vasculature is following right along in its development. So all of a sudden it becomes apparent that if anything interferes with the development of the tracheobronchial tree, one will also have interference with the development of the pulmonary vasculature. And in 1977, Dr. Nate Weissman and his associates suggested that we might look at congenital diaphragmatic hernia, and they classified them based on the development of the lungs. They knew that there were instances in which there was bilateral hypoplasia, and these patients did not survive. They were sick soon after birth, and they did very poorly. And I guess at the same time one must recognize the fact that the gut comes back into the abdominal cavity at about 7 or 8 weeks of intrauterine life. The pleuroperitoneal canal is supposed to fuse about the same time. If that relationship becomes upset, then it's possible that a very large amount of bowel can enter the thorax at a very critical time, the 10th week or so during the development of the lungs. If it's large in amount, it'll compromise the lung on the ipsilateral side, shift the heart to the opposite side, and that will compromise the development of the contralateral lung. There are those instances in which there's unilateral hypoplasia, and some of these survive, but just as we've seen, they may have abnormal vasculature and what appears to be emphysema. Then there are those who have insignificant hypoplasia, and there you can suggest that in fact the volume of gut that went up was very small early on, or the bulk of it went up toward the end of pregnancy, at least after the 14th week. And then there are a group in which there is no hypoplasia, and these do very well. Well, this is an instance of a child, and I would emphasize a baby who was found to be short of breath at 24 hours. And right away, that's a clue that the hypoplasia is not going to be too bad. The child went to the operating room, and on the first film made in the recovery room, the lung on the side of the hernia is of normal size, and the vasculature is normal, and 7 days after operation, the chest is perfectly normal. We can assume here that this hernia, or the bulk of the gut that went into the chest, went in well after the 4th month of pregnancy. A baby 1 day of age who was thought to have pneumonia. And the lungs don't look normal. They are a little over-aerated, and there's some fuzzy density. And as a matter of fact, there was a question on the 2nd day as to whether or not there might be some fluid in the hemithorax on the right. On the 3rd day, this became very apparent. By the 8th day, there was increasing density in this lung, and now one can see the hepatic flexure, and this child has a diaphragmatic hernia. It wasn't present at birth. It was becoming apparent over time. The child also had beta streptococcal pneumonia. And there is an association, for unknown reasons, unknown to me at least, between beta streptococcal infection and the late appearance of diaphragmatic hernia. I suspect that because of the infection, the patients cough, they might get physiotherapy, and a potential hernia becomes a real one. In any event, this child went to the operating room and did extremely well, and there was absolutely no problem post-operatively. Just as you would expect, there was no abnormality in the development of the lungs. On the other hand, this baby was sick within the first hour or two of life and has a large diaphragmatic hernia, went to the operating room, and noticed the size of this lung. Post-operatively, it's tiny. And the amount of intestine in the chest was such that it couldn't be replaced, and so it was put in a silastic bag, and there we see it. And then the diaphragm was repaired. But this child became quite cyanotic and went to the cardiac catheterization laboratory because of the question of some sort of complex congenital heart disease. At that time, nothing was found, but pulmonary resistance was very high, and there was marked right-to-left shunting through the ductus arteriosus. A catheter was placed in the pulmonary artery, and priscaline was started as a drip. Now, in retrospect, that probably didn't do any good. It didn't do any harm in all likelihood. But by the second day or so, the shunting abated, and the catheters were removed, and about 2.5 weeks after birth, this child went home. So this is a baby who had very labile pulmonary resistance and became very cyanotic secondary to changes in the vasculature. Now, these vascular changes, as we followed the baby, became very apparent. This lung gradually got bigger to fill the hemithorax, but notice the vessels. And so this child will live forever with this sort of vascular abnormality. And so it becomes important, I think, to recognize the fact, since many of the babies who have severe hypoplasia, unilateral hypoplasia, are able to survive, it becomes apparent that as they survive, we may see later in life this sort of alteration in the vasculature and, in fact, in pulmonary perfusion. Well, let me say a bit about this. This is a patient who has recovered from the repair of a left diaphragmatic hernia, and this is the sort of emphysema that has been described. And I don't know if it's emphysema. I know that the vasculature is diminished, and this lung looks larger than its mate. And it's problematic as to whether this is, there's this normal overall lung volume gets, it becomes normal, but then it gets a little bigger. And is that because there is an increase in the number of alveoli, or is it because there's an increase in the size of the alveoli, or is it because it's a combination of both, and it looks worse because of the vascular abnormalities? I don't know, but this is another patient who, as an adult, will have a very confusing examination of the chest radiologically, and would be quite a problem if one did not have history and then, in addition, did not understand how this happened. Well, it becomes apparent that hypoplasia of the lungs is important, but the vascular changes are equally or even more important. In the fetus, musculature in the vessels extends down to about the region of the terminal bronchi, and then as the child gets older, we know that the musculature extends further and further peripherally. But in patients who have pulmonary hypoplasia associated with diaphragmatic hernia, the vessels are not only reduced in number and diameter, but they're more muscular for size. The muscle extends into the smaller and more peripheral arteries. And as a result, there may be a very reactive vascular bed in the lungs, or there may be one with fixed high pulmonary resistance. And in a little study being done at our hospital, Dr. Vacanti and Dr. Crone, others who are taking care of these babies clinically, have looked at those with congenital diaphragmatic hernia and divided them into those who are at low risk and those who are at high risk. And the high-risk babies almost uniformly present within the first 6 hours of life with severe symptoms. And these can be divided into those who respond. They're responders during anesthesia. Their pulmonary vascular resistance becomes low. It may stay low for a while, the so-called honeymoon period, but it is very labile, and with suctioning, with loud noise, with lots of things, it can go to alarming heights. But in these responders, the postductal PaO2 is greater than 100 torr, where the non-responders who seem to have fixed pulmonary vascular resistance, the postductal PaO2 is less than 60 torr, and they do very poorly. And typically those non-responders have smaller lung volumes and weights, reduced external diameter of pre- and intra-acinar arteries. The muscle goes way down. Increased medial thickness of normally muscular arteries, muscularized intra-acinar arteries, and failure of perinatal increase and compliance in those small pre-acinar muscular arteries. So the vascular bed is very important. And in the protocol, post-operative angiocardiograms have performed, or pulmonary arteriograms, and this is one who is in the good group. And with the injection into the pulmonary artery, one can see that the size of the pulmonary vessels is normal. And this is one who was a responder but died of intracerebral hemorrhage. And I would point out that the contralateral vessels are normal in size. The ones to the hypoplastic lung are tiny, and this was a non-responder. And as the lungs are small, look at the size and the decrease in number of the pulmonary vessels. And here we see them again, that responder who died, and here we see the small vessels died of non-pulmonary causes, and this is a non-responder, and one can see the difference in the vascular anatomy. And so that the high-risk infants with congenital heart disease can be divided into two groups, responders and non-responders, based on their physiology. The high-risk responders have inadequate pulmonary circulation, chronic administration of anesthesia, and we've been using fentanyl preoperatively, intraoperatively, and postoperatively, has helped in reducing the episodes of cyanosis related to the lability of the pulmonary vascular bed. Vasodilators don't seem to help, and the non-responders are being treated now, and I'm sure they are here as they are at home, with extracorporeal membrane oxygenation in the hopes that they can be kept alive until their vascular bed matures or remodels. But the only reason for going through all of this is because as these babies with severe pulmonary vascular abnormalities survive, then the as adults, they will have a very abnormal pulmonary vascular appearance by routine radiology. Well, let's move on a moment to infections. I don't know that one usually equates infections, which are very common as they involve the respiratory tract in infants and children, with disease in the adult. But these are the film studies of a baby who had respiratory syncytial viral infection. And as one expects, there's very little in the way of visible exudate, but the lungs are huge in volume. The diaphragm is quite flat, almost concave. The chest is increased in its AP diameter as the accessory muscles of respirations attempt to pull up on the soft thorax, the interspaces are wide and the anterior ends of the ribs are elevated. And I think under a year of age, this over-aeration in association with a host of pulmonary infections is the rule. And there are good reasons for this. The peripheral airways in infancy are tiny, but they're probably relatively tiny as compared with the adult. The collateral pathways of ventilation are poorly developed. The airways are more collapsible with changes in pressure and are less rigid than in the adult. There's more mucus formed. There are more mucus glands, and there's some evidence that the mucus is of different chemical consistence early in life as opposed to later in life. And there is a relative immunologic incompetence in the first months of life. Well, if one thinks about the fact that these airways are tiny, that they are easily compressible, and that maybe because of the immunologic incompetence, infections tend to be diffuse. If the small airways are involved, there will be an increase in peripheral resistance. If there's more mucus and poor collateral channels of ventilation, then atelectasis may be explained and can be expected. And I think a lot of what we call bronchopneumonia in this age group, in fact, represents areas of, say, segmental or subsegmental atelectasis. Well, not all babies, unfortunately, with bronchiolitis do well. Some have recurrent disease, some become, quote, asthmatics, and it's a suspicion that reactive airway disease, as a consequence of viral infections in early life, may persist into adult life. But there are other consequences of these viral infections. This is a baby 10 days of age who, as it turned out, had adenoviral infection as well as respiratory syncytial viral infection. The lungs are huge. There's an area of probable atelectasis. However, at 3 weeks of age, this baby was not better, and the lungs are large, and there is all this confluent opacity in the lungs, and I'm not sure I know what it is. Is it exudate? Is it transudate? Is it associated with atelectasis? I don't know. But this baby did poorly. And by 38 days, the lungs are huge, and by 44 days, we see that there's increasing volume loss in the right lung. The left lung is huge. At 63 days, a day before the baby's death, the left lung occupies most of the thorax. And a post-mortem study, this baby had severe bronchiolitis obliterans involving both lungs, more peripheral on the left and more central on the right. And this is a consequence of a number of infections. For example, a 5-year-old with measles pneumonia who got better from that but then became breathless, and his chest changed in configuration considerably as the lungs became huge. And Dr. Nancy Wong, who is the pulmonologist in our hospital in Philadelphia, kept asking me what I thought was going on, and I was afraid I didn't know. And I looked at the overall opacity of the left upper lobe and thought that there was chronic pneumonia there. But we finally did bronchograms on this child, and what had happened was that with the viral infection associated with measles, this child had developed severe bronchitis obliterans. This is expiration, inspiration, and nothing went past this point. There was a tiny bit of normalcy, if you will, in the anterior segment of the upper lobe on the right. And with the left side, the part of the lung that I thought was abnormal is the only part with a normal bronchial tree, the apical posterior and anterior segments. This was about 25 years ago, and we didn't have good nuclear medicine, so a pulmonary arteriogram was performed, and that opacity that I saw was related to that part of the lung that was perfusing, the part that had a normal bronchial supply. Well, I talked to the pediatrician who took care of this child, a year or so ago, and I said, "What happened to David?" And she said, "Well, he was just in the office, and here he is at 23 years of age with a chest that looks very much as it did when he was acutely ill at 5 years of age, and he still is pretty much breathing on 2 segments of his left upper lobe." So there's no question that one of the consequences of pulmonary infection in the child can be obliterative bronchitis, and depending upon the severity and the diffuseness of the involvement, we may or may not see those children again well into adult life. And of course, the other thing is reactive airway disease. Now, I'd like to finish with a little discussion of cystic fibrosis. At the Children's Hospital, under the aegis of Dr. Harry Schwachman, we've had a large experience with patients who have cystic fibrosis. And I think as we all think about that disease, we know it's genetically transmitted, that it's characterized by dysfunction of the exocrine glands, that its incidence is about 1 in 2,000 white children. The symptoms are, as a rule, respiratory and gastrointestinal, that its diagnosis is made by elevated sweat chlorides and sodium, and that when this slide was made, which was just recently, the median survival, surprisingly, was about 20 years of age. But most of us think of cystic fibrosis as seen in this baby, with overaeration and atelectasis of the right upper lobe, or in this infant who has severe overaeration, patchy atelectasis, and has very severe disease, or this 14-year-old who is very close to death because, as you can see, there's marked overaeration of the lungs, the thorax is deformed, and there's peribronchial thickening throughout and bronchial plugging. But it is interesting as you look at survivals. It wasn't too long ago, and from 43 to 64, that very few patients survived past 15 years. And then from 1964 to 1968, there was increased survival. 69 to 73, further increase. And in a recent book by Dr. Lynn Taussig, he shows survival, and these are patients who have not had meconium ileus, that at 30 years, there's almost or even better survival than there was at 15 years, 20 years ago. Now, why is that? I think for several reasons. Maybe we know how to treat the patients a little better. Maybe we treat complications better. Or maybe we also recognize the spectrum. I was interested to look at our own statistics a couple of years ago to find that under 14 years of age, those with cystic fibrosis, there were 72 admissions for 912 patient days. From 15 to 40 years of age, there were 259 admissions, 78%, and 3,222 days. So that there's no question in our own hospital that cystic fibrosis and the terrible aspects of it are being encountered in adults. And they prefer to come back, I think, to our hospital, as is probably true here in pediatric medicine, because the physicians who are taking care of them are those who took care of them for most of their life. And Dr. Schwachman and his associates 9 years ago looked at the age and sex distribution of 70 of his patients with cystic fibrosis over 25 years of age. And at that time, notice the age and the number of patients. Some of these, the oldest was 44 years of age. Now, they have a host of pulmonary problems, as you well know: bronchopneumonia, bronchiectasis, atelectasis, emphysema, pneumothorax, cor pulmonale, nasal polyps. He taught us, and I think it's still true, that a patient of any age who has nasal polyps has cystic fibrosis until proven otherwise. It was also interesting to see the diagnoses that were entertained and for how long before the diagnosis was made. And for some, it was years before the diagnosis was made. They were carried as bronchial asthma, bronchiectasis, celiac disease. Many of them had delay in sexual maturation. Some were encountered in fertility clinics because of the known lack of fertility in both males and females. And the hospital admissions of those patients before the diagnosis, 32 patients were hospitalized 110 times before the diagnosis is made. So it's apparent that what we consider as the usual findings in cystic fibrosis may be very confusing. It's also apparent that the findings may not be typical in all patients. And this is the cut lung of a patient who expired, showing the bronchial plugging that is so common in the bronchial ectasia, and here the inflammatory disease that is destroying the mucosa of the bronchus and extending into and beyond the bronchial wall. And here's a patient with huge plugs in ectatic bronchi, and this is the way they look. And these are relatively typical findings. But I would point out that there's a very real spectrum. This 18-year-old was carried for some year and a half as an asthmatic until someone realized there was not a good history for asthma and that there were some GI complaints. And the sweat test was done, and this is a perfectly normal chest x-ray. In this adult, I think it would be very difficult to make the diagnosis of cystic fibrosis, but that is the diagnosis. This one at 30 has some thick-walled bronchi and a little bit of plugging, and we see a patchy area of atelectasis here and here, but that is not typical, as is this patient. I don't think any of us would quarrel with the diagnosis here. So there's a very real spectrum of this disease. And not all are malnourished, as we see in this 40-year-old man with cystic fibrosis. And sometimes if you look at the shoes, you can make the diagnosis. Because of the high sweat chlorides, they rust through their shoes in about 6 months. The same is true with hat bands as well. One of the complications that is so important to recognize is cardiac failure, and this is due to cor pulmonale. Although sometimes because of shunning through bronchial vessels, there's stress on the left side of the heart. And I know of no more important disease in which one must have previous films for comparison than this. Because this heart doesn't look too big until you compare it to the way it was when the patient didn't have cardiac failure. Another complication is pneumothorax and pneumomediastinum. And the only thing that I'd like to say about that is that one must be very careful as you look at the films of patients who have pneumothorax and in whom a tube has been placed to be sure that the tube is in the pleural cavity. In this instance, for the simple addition of that sort of oblique film, it's apparent by triangulation that that can't be in the pleural cavity. It was draining air, but it wasn't in the pleural cavity. It was removed. The patient expired a week later, not because of the tube, and there was the tract of the tube through the lung. So I think as you look at babies or at adults or children who have chest tubes, it's awful nice to have that lateral film, at least initially, to know where the tip of the tube really is. 14-year-old, and I point out pneumatosis of the colon. And here's a resected specimen of a patient who in fact had been thought to have multiple polyposis, but this represented pneumatosis of the colon. We were interested in that, and we recently looked at our patients who came to postmortem study and found that there were about 200 patients from 1944 to 64, and only 1% of them had pneumatosis of the colon. From 64 to 77, there were another almost 200, and about 6% of them had pneumatosis. And from 77 to 94, 11% had pneumatosis. These were, as a rule, older patients, but interestingly, they all had some sort of air block phenomenon that could be documented clinically, radiologically, or at postmortem study. And it's likely that this pneumatosis intestinalis, which almost always involves the colon, is a result of establishment of pathways from the mediastinum down into the mesentery, along the vessels, and into the wall of the bowel. Patient with cystic fibrosis who has hemoptysis, and he's 32 years of age, and this is something that, whereas Dr. Fellows in our department spends a modest amount of time embolizing those vessels, the big bronchioles that supply areas of chronic inflammation. The only thing I'd like to point out is that in the older patients, not all of what we see in the lungs represents inflammation. It's obvious that a lot of this density is vasculature and is related to the huge bronchial vessels. And in this man, at postmortem study, one could find many pulmonary artery, bronchial artery communications. And this is a typical example of a huge bronchial that was successfully embolized in the treatment of this patient's hemoptysis. Just a word about nasal polyps. They're not benign. This little girl at 4 years had nasal polyps. They were operated on many times. They recurred. This is what they did to her face over time. And radiologically, she's alive at 30 years. One can see the adaptive changes in her bone, nasal bones and orbits to those nasal polyps. CT, I think, has a role to play, and this shows very nicely in a patient the huge cystic bronchiectasis and the thick-walled bronchi. But what it doesn't tell us is whether all of those densities in and around the hilum are vasculature vessels or whether they represent nodes. And I think that, as Dr. Gooding and his associates have shown at the University of California at San Francisco, there's a role for MRI in clearly differentiating flowing blood in big pulmonary hilar vessels from lymph nodes. So I think that there's the good possibility that this will add immeasurably to our ability to evaluate patients who have cystic fibrosis. Now, I'd like to close with this patient. Dr. Schwachman, he always developed a very close relationship with his patients, and he was very proud of their achievements. And there were doctors and lawyers, or are doctors, lawyers, accountants, PhDs among his patients, all of whom had cystic fibrosis, and not all of them had easy disease. And this is one, a young woman that a couple of years ago, he took me out for an introduction, and I had all of her films from the time she was 1 day of age when she presented with intestinal obstruction in meconium ileus. At 5 days, her lungs were a little large in volume, but otherwise they were pretty normal. But unfortunately, she developed atelectasis of her right middle lobe, and it was persistent, and she was known to have cystic fibrosis by this time, and so that was resected. And then here she is at 7 years with lungs that are of large volume. By 11 years, peribronchial thickening and bronchial ectasia are becoming apparent. By 17 years, her lungs are obviously grossly abnormal. But she started college at that point and got eventually her master's degree. And at 26 years of age, she was teaching nutrition in one of the local colleges, and one can see that she has pretty severe disease. And unfortunately, she died at the age of 28, having received her PhD. So that this is an unusual opportunity to follow this dreadful lesion. Example examination of the chest in the hospital as she delivered her first baby. And it's a pretty interesting looking chest with this strange bony abnormality, scoliosis, and what looks like a tumor. Well, I remember her very well because 24 years before, she came to our hospital with this x-ray. She had had this one on the second day of life, and someone thought she had a bunch of bony anomalies and didn't do anything. But by 3 months, she was short of breath, and this was her chest film. She went to the operating room, and a biopsy was done, and the frozen section was chondrosarcoma, but I don't believe it. But no one was much interested because she was exsanguinating, but the bleeding stopped, and the parents said thank you, and they signed her out. And when the permanent sections came through, she was found to have a mesenchymal hamartoma of the chest wall, a lesion that was once thought to be malignant, but is now known to be benign. She bled because there are huge bloody lakes within these, akin to almost aneurysmal bone cysts. So there she is at 3 months, and she went home. And here she is at 5 months, and it's fascinating to follow this untreated huge lesion. And at 10 months, we see the ribs are starting to reconstitute themselves, and here she is at 4 years. And the ribs are coming back, and she's growing away from that mass, and she's asymptomatic. And here she is at 10 years developing scoliosis, but the mass has all but disappeared. And here she is at 24 years asymptomatic and having delivered a baby. So that if we had thought that this was a malignant tumor early on, this sort of evidence, along with a few other patients in the literature, allows you to think that this strange lesion that almost always involves the chest wall is probably in fact a hamartoma and not a true neoplasm. So in summary, I'd just like to tell you again how pleased I am to have had the opportunity to be here this afternoon. And what I've tried to do is to suggest that there are patients, pediatric patients, who have diseases that we characterize as pediatric. But those patients grow up, and we're apt to see the lesions in a little different setting on one hand, or we're apt to see the residual of the treatment of the lesions on the other hand. And if we understand the genesis, then I think we can understand not only the radiographic findings, but the altered physiology. Pulmonary infections, we don't think of much, but there of them much as having residuals, but they do. And cystic fibrosis, I'm afraid, is becoming a disease that's as much interest to the internist as it always has been to the pediatrician. Thank you very much.